Yes, thank you, Natalie, for the introduction, and thank you, everybody, for joining. So in my part of this presentation, I'm going to talk basically about the prenatal management approaches and the focus in the prenatal diagnosis and prenatal counseling. So congenital diaphragmatic hernia is a disorder that is in itself primarily a relatively trivial defect, but it can lead to a lot of downstream effects, both in terms of pulmonary development, vascular development, and it can be associated with additional morbidities that altogether can have an impact on the overall outcome. Most of the diaphragmatic hernias, and this is looking at the diaphragm from the bottom up, are on the left-hand side, that's 80%, right-sided hernias about 20%, and then a smaller proportion of hernias are the more Gagny hernias that are all on the anterior portion of the diaphragm. And so the traditional Bauch-leg hernia, which are the ones that are prenatally typically diagnosable, make up 75% of the CDH volume. Now, the principal impact of a congenital diaphragmatic hernia is basically that because there is intrathoracic herniation of abdominal contents, there is a contralateral mediastinal shift. And depending on which side the hernia is, the contents of the thoracic cavity can contain the liver, which is mainly found in right-sided hernias, or if it's a left-sided hernia, you can have multiple abdominal organs in the thoracic cavity. Now, what that does is it produces a proportional degree of contralateral lung compression. So that means the more there is in the chest, the less space there is for the lungs, and there's lung compression. And that is the single biggest contributor to remodeling how the baby's lung or the fetus's lung matures. So the prenatal diagnosis is basically based on the principles what you would expect to see if there's a hole in the diaphragm. So normally you have at the view of the four-chamber view on prenatal imaging with the left side and the right side indicated on the image, you have basically the heart roughly at sort of 45 degrees with the interventricular septum. When you get a diaphragmatic hernia that is on the left-hand side, there's basically displacement of the heart to the other side of the hernia or anteriorly. And what the displacement or the magnitude of the displacement depends really on the size of the hole. So on the left-hand side, you can see here that there's a stomach herniated backwards. The overall rotation of the heart is not that marked, but clearly there's something that is behind the heart in the thoracic cavity that shouldn't be there at the level. Here in this example on the left-hand side, you actually have a bit of stomach, a little bit of bowel, a little bit of liver. And here you have a heart that's entirely displaced over to the right-hand side. So anytime we see either a rotation of the axis away from its normal left-sided direction, you got to wonder about if there's left-sided intrathoracic herniation through an opening into the chest wall. The opposite happens in right-sided hernias, that where you see here that the heart is sitting more towards the left-hand side, and that's because there is liver herniation on the right-hand side into the chest. So that's sort of the hallmark that defines what the typical abnormality is that you would observe in diaphragmatic hernia. The abdominal contents, again, depend on the side of the hernia. And then there's sort of some other findings that you often find, particularly with right-sided hernias, about 10% have pericardial effusion. And with left-sided hernias, that percentage is a little bit lower, but it is basically due to the intrathoracic herniation of abdominal contents as well as fluid. So here is an example of what a right-sided and a left-sided CDH would look classically. About 60% of diaphragmatic hernias are diagnosed prenatally. And as a rule of thumb, the earlier you see it, the more severe the hernia likely is. So here on the left-hand side, you see a CDH at 13 weeks or at 16 weeks. I showed these before. So an early CDH is likely to be a large one. CDH can be a sporadic defect that exists by itself, or it can be associated with a number of other underlying genetic or non-genetic syndromic conditions, and these are associated with variable other anomalies. So anytime you do see a diaphragmatic hernia, you really need to check off these findings that might point towards the underlying syndrome or some genetic problem. Now, the overall outcome, both in fetal life, early neonatal life, as well as up until 2 to 3 years of life, is fundamentally strongly influenced by the size of the hernia. So the larger the defect, the higher the risk of respiratory morbidity, gastrointestinal morbidity, and developmental impacts, because the more lung support you need with, for example, ECMO and other therapies we're going to be talking about later on, the higher also the risk that you have episodes of cerebral hypoxemia, which then do have an impact on long-term development. So the survival basically drops as the hernia size gets bigger, and as far as additional anomalies, the presence of a cardiac defect has probably the biggest impact on overall survival. So our focus in prenatal planning is then that you want to have a comprehensive diagnostic assessment for associated anomalies, especially cardiac, and you want to have a comprehensive assessment of the genetic abnormalities. And then we turn to sort of assessing the severity of lung disease that can be anticipated after delivery, because that is sort of, in very simple terms, the immediate killer after birth that can happen. Traditionally, the lung size was normalized for the fetal head size in a ratio that's called the lung to head ratio. But as you can see here, the lung and the head don't grow at the same rate across gestational age. So the LHR physiologically goes up as you get further along in pregnancy. So an LHR of 2 might be normal at 16 weeks, but it would be grossly abnormal at 28 weeks. So because this parameter is not constant across gestational age, we have really moved away from that, and we are now measuring the relative lung size as a fixed percentage in what is called the observed to expected lung to head ratio. And the simple way we explain it to parents is like, well, what's the percentage of the lung size? And the stratification into mild, moderate, or severe hernia is based on the lung size as well as the liver position in the chest. And this is the severity assessment we use for left-sided hernias. For right-sided hernias, the relationship with survival is not the same. And in fact, the survival chances are lower for the same O2E LHR, and we use some specialized and different counseling approaches for that. In the North American Fetal Therapy Network, we've done extensive research. What is the best way to measure the lung size? In the technique where you take the measurement of the lung at the level of the four-chamber view and you trace that, that is actually the most reproducible and most accurate measure to calculate the O2E LHR. Also important to recognize that there is variation over gestational age in these measurements, so it's not a fixed variable. You can have babies that start with an O2E at 20% at 18 weeks, but they go all the way down to 15 or 10% 2 or 3 weeks later, and other ones can actually have some increasing lung growth, and the value might be above this critical value of 25 that we consider severe. How to approach that in terms of the prenatal counseling has not been figured out yet, but we certainly take that into account and discussed it with our parents. Now, in terms of the other imaging modality that's relevant is magnetic resonance imaging. So you can look at the lung volumes both with ultrasound and MRI, and to a certain degree that is your preference. We do obviously prenatal imaging. So we use the ultrasound imaging and we look at the liver position. The MRI read will tell you the percent liver herniation. The other thing that you might have heard about is the stomach grading. So that's basically how far is the stomach up in the chest, and is it all the way behind the heart, or is it just sitting on the left-hand side? The same exists in MRI imaging. And then the latest is sort of the mediastinal shift angle. If you look at all these variables and sort of try to parse out what they're telling you, well, the lung measurements tell you about relative lung size. The liver herniation is sort of the position and the percent liver herniation. And the other variables tell you about the degree of mediastinal displacement. All of these depend on the size of the hernia and therefore correlate with survival. And when you sort of compare all the different variables, and this is sort of a more recent meta-analysis, it is really fairly comparable. And what is the most important thing is where your expertise is. So in centers that have marked expertise with MRI, the MRI prediction might actually be better. Now, for a subset of patients, there is prenatal treatment, and that's the fetoscopic tracheal occlusion. The principle is that by blocking the trachea with a balloon, you basically stop the egress of lung fluid, and that leads to lung growth. And then after you remove the balloon, the baby can then be delivered and has a patent airway, but has hopefully better lungs. The principle approach is shown in this video. This is sort of a fetoscopy at 28 weeks. We're getting into the fetal mouth. The baby is paralyzed. Here is the midline raphe that tells us where the midline is. And we will follow that back towards the ovula. And because the baby is paralyzed, you can actually extend the oropharynx with saline installation. And then we will basically advance past the epiglottis between the arytenoid folds and enter the fetal trachea. And when we do that, we will inflate a balloon that is going to be kept inside for about 5 to 6 weeks, ideally. And what that does is it basically blocks the lung fluid, and that leads to a lung growth. Here we're going sort of past the, seems that my computer is slowing down a little bit. Normally this goes a little bit faster. Anyway, once the balloon is placed in the trachea, we follow with serial ultrasounds, and what we can actually demonstrate is that the lung size tends to at least double. And once we remove the balloon, then there is a decrease in the lung size, but the overall lung size ends up in a different severity category than patients started. And both the randomized trials and single center analyses show that for severe hernias, there's a significant survival benefit over twofold after fetal treatment. And with a notable difference in the survival outcomes in European centers and US centers. The data are shown here, but also here in the US fetal group, which was basically 7 fetal centers in US that collaborated together. And here we were able to achieve a 6-month survival of 70%, which is several fold higher than what you observe in the European study. One of the important factors that seems to affect survival chances are basically how your program is set up. And here in this meta-analysis, we sort of compared CDH programs where you have a fetal therapy center that works hand in hand with an integrated neonatal program and a pediatric surgical program versus the ones where the fetal therapy is done somewhere else and then they deliver in a CDH program elsewhere. And what basically this showed is that integrated programs, so where everything is together, really have significantly better survival chances. And a large factor seems to be the access to ECMO, as well as the experience with ventilation strategies. So from a prenatal perspective, our focus is to manage some risks that might be associated with diaphragmatic hernia, such as fetal polyhydramnios that can predispose to preterm labor and cervical shortening. So we are very aggressive with treating that with tocolytics to provide a comprehensive risk stratification that can tell us if a patient is a candidate or not for fetal therapy. And then also assessing other risk factors that have an impact both in terms of cardiac anatomy, but also in sort of the development of the left ventricle, which is often smaller in babies with left diaphragmatic hernia. And then to really have a coordinated delivery plan where the parents have met with a neonatology and pediatric surgical colleagues before delivery, that we try to get the delivery in the beginning of the week, ideally at daytime, and then a labor management that we are really stringent with the fetal heart rate monitoring, that we can anticipate a normal pH at the time of delivery. And we then have a coordinated delivery setup with the neonatology colleagues. And with that, I would like to hand over to my colleague, Dr. Desiraju, who's going to talk about the neonatal management focus.
Thank you, Ahmed. Share my screen. All right. Well, good afternoon, and thank you for having me today to speak about CDH. I'm Sunita Desiraju. I'm a neonatologist, and I'm going to talk about CDH management in early life, from the time of delivery to the time of operative repair. Now, the management of CDH in early life is very unique because it's concurrent with the transition to ex utero life. And of course, we neonatologists are all so passionate about fetal to neonatal transition. So today I'd love to talk about how CDHs transition and how to keep them safe during that transition. Now, there's a wide range in CDH phenotypes, just like Dr. Bashat mentioned, associated with other anomalies and genetic underpinnings and so on. So today I'm going to focus on general physiologic principles that apply to all newborns with CDH. So today we're going to start by identifying the differences between typical patients and CDHs and how they may differ in fetal to neonatal transition. I'll use a couple terms to help us all understand the interdependence of cardiopulmonary interactions. I'll be talking about V for ventilation and Q for perfusion or pulmonary blood flow. And specifically, we're going to be talking a lot about VQ matching. And then we'll identify some transitional management strategies for supporting ventilation, pulmonary blood flow, and cardiac function. So let's start by talking about fetal to neonatal transition in the lungs. And I like to tell trainees that every day is match day. And what I'm referring to here is a VQ match, whether we're talking about VQ matching in utero or ex utero. In utero, the lungs are filled with fluid, both amniotic fluid as well as fluid produced by the lungs. And they're in a low V state, a low ventilation state. Along with that, they experience hypoxic vasoconstriction, which is a low Q state, low pulmonary blood flow with high pulmonary vascular resistance. That's a VQ match. Now, once they're born, the healthy baby starts to cry, which improves ventilation, therefore improving pulmonary perfusion. So now we're in a high V, high Q state. And this would happen to CDHs as well. But I'll talk a little bit about how we alter their care. Next, I want to go into talking about the heart and fetal circulation. And I mean, we could talk about the fetal heart all afternoon, but I'm going to focus on two specific points. The first, I'd like to draw your attention to this stream of very oxygenated blood, this red blood right here, that's going towards the left side of the heart. And it skips the right side of the heart to end up solely in the left side of the heart. And this process is called preferential streaming. And I'm mentioning this in particular because it does play a role in CDH pathophysiology that I'll show you in just a couple slides. The second thing I'd like to point out about the fetal heart is that there are two connections that allow the opportunity for parallel circuitry. The first is the foramen ovale, which connects the two atria. And the second is the ductus arteriosus, connecting the great vessels, the pulmonary trunk and the aorta. Now, because of parallel circuitry, there's an opportunity for a differential in oxygenation between the pre and postductal circulations. And that plays out ex utero with CDHs, and we can even utilize it to our advantage. Let's talk a little bit about CDH anatomy. And Dr. Bashat showed you some beautiful pictures, but here in a pictograph form, we see that in CDHs, the intestines have taken over the real estate of the thorax, and the lungs and heart are underdeveloped. And so therefore, with hypoplastic lungs and hypoplastic vasculature, we need decreased inflation in order to achieve maximal or optimal ventilation. And we should expect that maximal Q, or pulmonary blood flow, is lower than in a typical baby. Additionally, the left ventricle is underdeveloped and prone to dysfunction. Let me talk a little bit in detail about this cardiac maldevelopment. Now, this is an image, a simplified image of fetal circulation that is in typical babies, structurally normal babies. And what we see is this phenomenon I mentioned a couple slides ago about preferential streaming, where the reddest, most oxygenated blood travels directly from the placenta through the right atrium to end up in the left atrium, with the purpose being to grow and develop the left side of the heart, to remodel and take over as a systemic ventricle ex utero. This process is impaired in CDHs and is due to so much anatomic distortion that's present in utero that interrupts this process. The second change in the CDHs is that there's less pulmonary venous return to the left atrium. Now, even in typically developing babies, there's very little pulmonary venous return to begin with. Perhaps only 10% of cardiac output from the right ventricle goes towards the lungs in the first place. So to cut that in half or more is impactful. Putting those two facts together, we see that we have an overall reduction of oxygenated blood flow to the left ventricle in utero. The other factor is that we have mechanical compression of the heart. And so it's just not possible for the heart to develop exactly the same way as it would in a structurally normal child. So putting all this data together, how are we going to transition the baby with CDH? Just like in structurally normal babies, we would like to optimize VQ match. Now, in a structurally normal baby, all we have to do to optimize ventilation is stimulate them to make them cry. In a patient with CDH, we intubate in the delivery room, and we're in charge of deciding how to ventilate the baby. So we're going to choose to ventilate using CDH appropriate pressures. We'll talk a little bit about what those pressures should be in a little bit. We're also going to expect their respiratory rates to be high. Now, I have tachypnea here in quotation marks because they're tachypnic relative to the babies that go to newborn nursery. But realistically, this tachypnea is physiologic. They have less parenchyma than the structurally normal child, and therefore the tachypnea is a tool that they use to maintain minute ventilation. So we can utilize that to our advantage. So now we've talked about V. The whole point is to attain a VQ match. In a patient with CDH, we need to be patient with Q. Q is going to come a little slower. And with that patience, we're going to avoid empiric pulmonary vasodilation. We're going to let them prove their need for vasodilators before we just start them. We'll see that the preductal SATs will meet our SAT goals first. Postductals will come up a little more slowly. And we'll be judicious about which patients we actually use nitric oxide in. Now, there's this concept of the honeymoon period in CDH. And historically, a lot of people say the honeymoon period lasts the first 24 to 36 hours, which is right around the time that the ductus closes in a structurally normal child. So our goal now is to prolong this honeymoon. We're going to start prostaglandins for ductal patency. And starting prostaglandins and maintaining ductal patency means that we're going to maintain persistent fetal circulation, which some of you may recognize is the old term for PPHN. We're going to utilize fetal circulation as a tool. I'll talk a little bit in a couple slides about how cardioprotective this is. Let's go back to VQ matching. Now, V is in our hands. We can choose how we ventilate the baby, and the goal is to attain Q. And this graph that I have here, classic physiology principle with lung volume on the x-axis and pulmonary vascular resistance on the y. Now, what we see is that lung volume ranges from residual volume or atelectasis all the way up to total lung capacity or hyperinflation. Pulmonary vascular resistance on the y-axis is the inverse of pulmonary blood flow, the inverse of Q. So if we want to set our ventilation in such a way that we attain the most optimal Q, we're going to ventilate right at this point here at FRC, functional residual capacity. Functional residual capacity ventilation is always associated with a nadir in pulmonary vascular resistance, not just in CDH and not just in PPHN, but in all neonates, in all patients. So how do we find FRC in patients with CDH? This image was created by Dr. Satyan Lakshminarasimha, who most of you may have heard of him as a phenomenal medical illustrator, as well as expert in all things PPHN, especially CDH. And I want to point out a couple of things on this graph. The first is that we find FRC at a lower point in CDH than we do in RDS. And CDH is shown here in pink versus RDS or any other typical neonatal lung disease in green. So FRC is achieved with a much lower PEEP in CDH than in the average NICU baby. So we should set our PEEP lower accordingly. The second fact I want to point out is that we hit an inflation plateau at a lower PIP in CDH than in the average neonate. So in between these two pressures, our FRC and the PIP at which we reach inflation plateau is a very narrow range of effective pressures. So once we determine where our pressure should be, there shouldn't be a whole lot of titration on the ventilator. These patients stay pretty stable with similar settings throughout their first days of life. Now, how do we know if the pressures we've chosen are going well for the baby? Well, naturally, we're going to get some blood gases. And what I'm recommending here is that we use preductal assessments of gas exchange. And I'm saying this particularly to the audience of neonatologists who love umbilical arterial catheters, myself included. Umbilical arterial catheters are postductal. And I want to point out why this matters. On the left, I've shown an image of a healthy infant who would go to the newborn nursery. And on the right, a CDH. Now, their cardiac structures may be the same. They may be structurally identical. However, the child who's healthy and goes to the newborn nursery would have a ductus that shunts left to right, as pulmonary vascular resistance will have dropped enough to welcome that extra blood flow. The CDH, on the other hand, will have high pulmonary vascular resistance. So this blue deoxygenated blood in the pulmonary trunk is more likely to choose the path of least resistance, meaning the descending aorta, traveling right to left through the ductus, and therefore the blood that we sample from the descending aorta from the umbilical arterial catheter will be partially deoxygenated due to the fact that it's skipping gas exchange. So if we really want an accurate assessment of how gas exchange is going, we should take a preductal sample of blood. And here we place our arterial lines in the right hand, in the right radial artery, to assess preductal blood. Postductal oxygenation will be low to strategic maintenance of fetal circulation. We're creating the situation using alprostadil to keep the ductus open. Now, persistent fetal circulation is very cardioprotective. And I want to talk about the benefits of right to left shunting. And the best way to imagine what the benefits are is to think about how each ventricle would function if right to left shunting were not possible, if the ductus were closed. RV output in the setting of a closed ductus would completely go towards the pulmonary vasculature. 100% of it would go to the pulmonary vasculature. Early in life in a CDH, pulmonary vascular resistance is high and would present a great amount of afterload against the right ventricle that would eventually lead to burnout. Now, with regards to the left ventricle, we have cardiac maldevelopment affecting the left ventricle. So if the ductus is closed and we force all of RV output through the pulmonary vasculature, it will all egress into the left side of the heart, increasing preload greater than the left ventricle can handle. Now, this is a time-limited problem. The heart remodels postnatally, and so does the pulmonary vasculature. So until that process is complete, it's safer to keep the ductus patent, allow a detour for RV output as we have a gradual transition. Now, while I'm talking about protecting the heart, I'll say a note about vasodilation. I've put the title here as Avoid Empiric Vasodilation to Hasten Transition. Pulmonary vasodilators will make transition go faster, but they have side effects. Now, some CDHs need pulmonary vasodilators, but not all of them. So we want to be sure we understand exactly what the effects of a pulmonary vasodilator would be on the heart and lungs in these situations before we choose to use it. And the way we're going to do that is to follow the path of blood as it leaves the right ventricle. A deoxygenated drop of blue blood will leave the right ventricle to the pulmonary trunk. There it has the options of either crossing the ductus into the descending aorta or traveling into the lungs. Now, blood's always going to follow the path of least resistance. So if you've started nitric oxide, then presumably that path will be towards the lungs. However, there isn't as much pulmonary vasculature in a CDH as there is in a normal child. So some of this plasma will extravasate out and create pulmonary edema. What remains in the vasculature must egress back into the left side of the heart. But the left atrium has its own problems due to backup from the left ventricle, which is dysfunctional to start with. So to put that together, when we reduce right to left shunting, we can end up with pulmonary edema and exacerbate LV dysfunction. So this is a lot of information. I'm going to put it together in a summary of our recommendations for management. Now, ventilation is the absolute most important thing we do. We use low pressures to ventilate at FRC, functional residual capacity. We allow the baby to have high rates, and we use low inspiratory times to make those high rates feasible. Next, pulmonary blood flow. We talk a lot about pulmonary hypertension, but I like to think of this in the converse as in optimizing pulmonary blood flow. And the way that we optimize blood flow, or Q, is by optimizing V. Whenever we have a Q problem, we should troubleshoot V. And the way we know is by assessing oxygenation pre-ductally. Post-ductal assessments of oxygenation are pessimistic, and they don't always properly reflect what's going on at the level of gas exchange. We're going to avoid empiric vasodilation and only use pulmonary vasodilators when necessary, when the baby proves a need. Now, with regard to cardiac support, we're going to maintain fetal circulation until the ductus is reliably shunting left to right, at which point alprostadil is moot. And we maintain a low threshold to augment LV contractility. Here at Hopkins, we like epinephrine, hydrocortisone, but there's many other options too. So I want to thank you for your interest in CDH and thank you for joining this webinar. You'll hear next from our pediatric surgeon, Sean Kunisaki, who's going to tell you all about operative repair and follow-up. Thank you.
Thanks, Anita. Let me share my slides. Okay, I think that's the right view. So good afternoon, everyone. My name is Sean Kunisaki. I'm going to talk in the last 10 minutes or so about the postnatal surgical management of CDH and end with a discussion of some of our outcomes from the obvious multidisciplinary care of these patients.
Dr. Kunisaki, I think you need to switch screens.
How's that?
Perfect.
Perfect.
All right. Again, I'm the surgical director of the CDH program. I'm a professor of surgery here at Johns Hopkins. I have a fairly extensive experience with CDH, over 20 years. And we also have a multi-million-dollar funded research laboratory here with over 25 publications. So I think we're well suited to discuss kind of the surgical management of this condition. As most of you know, surgery, though, is really just a part of a very complex puzzle of specialists that are needed to take care of these patients. At Johns Hopkins, we really are engaged in this concept of a team approach that not only includes the ICU as well as our fetal therapy colleagues, but cardiology, pulmonary, and a lot of other specialists really to make this a successful endeavor. With regards to diaphragmatic surgery, really subscribe to a customized approach to surgical care. It's not only the what, but also the how and when. Surgical repair is not an emergency at birth. These kids all have had this hernia for their entire fetal life. And historically, it was thought to be a surgical emergency, much like a pneumothorax is, but we really do our due diligence and make sure we understand the child's physiology before going in and repairing the diaphragm. Repair generally is done within the first week of life, and that timing ultimately depends on the stability of the neonate. And there are minimally invasive versus open or traditional repairs, which I'll talk about in the subsequent slides. And then there are different approaches that we use to repair the hole, either primary repair, mesh repair, or increasingly muscle flap option is something that we've used and had a lot of success with. With regards to timing of repair, we review all of the x-rays and echocardiograms that are done within the first 24 to 48 hours of life so that we understand the issues in terms of ventilation and perfusion. We wait for stable ventilator settings as well as evidence that the pulmonary hypertension at least is controlled. And usually what that leads to is we wait 48 to 72 hours before deciding on surgical repair. This is a coordinated effort, of course, with our ICU doctors as well as our anesthesiologists. We take special care to have an experienced pediatric anesthesiologist who is very adept at managing these patients intraoperatively, because the worst thing we want is to worsen pulmonary hypertension or worsen the child's condition after repair of the diaphragm. In general, in terms of approach, if a CDH baby requires less ICU support, as defined mostly by the amount of support on the ventilator, as well as the use of vasoactive agents, babies are qualified for thoracoscopic repair or keyhole surgery, as it's sometimes called. This is actually done through the chest, and those babies typically are associated with hernia defects that are smaller. And the advantage of the approach is that there are not only smaller scars, but less pain. No chest tube is often required in these patients, and these are the patients who have much more mild disease, and we've had babies who have actually been discharged from the hospital as early as 2 weeks after birth. Many babies, though, do need considerably more ICU support, and these are children who are suspect to have a much larger hernia defect. And so the traditional or open repair, which is done on the left side for left-sided CDH, is our approach of choice. The slide or some rendition of it has already been presented, but I just want to review this again. In general, there are different defect sizes which correlate with the degree of severity of lung hypoplasia and pulmonary hypertension in CDH. It's graded on an A, B, C, D sort of grading scale as originally described by the CDH study group at UT Houston. And there is relatively equal distribution across the 4 different defect sizes, although at most of the major children's centers, like at Hopkins, our patient population is skewed towards the type C and type D defects shown there below. This is an intraoperative photograph demonstrating what a thoracoscopic repair looks like through a video camera. This is a pretty challenging procedure to do. We use 3mm instruments, high magnification, and a lot of experience to successfully get the diaphragm reapproximated. We're asked to essentially do very complex sewing of a very thin and fragile tissue through a working space that's about the size of a small orange. So it's a little bit challenging, but we're successful, at least for most of these smaller defects that do not require at least a large patch. These are x-rays kind of before and after CDH repair. On the left is what a typical x-ray would look like in a CDH baby prior to repair. You see that there is a oral gastric tube that's in place with the tip of the oral gastric tube ending in the left hemithorax. There is a small intestine as well as a small amount of liver that's herniating and completely filling the left hemithorax with the shifting of the mediastinum towards the patient's right. On the right side is an after picture in the same patient 12 hours later with the diaphragm fully repaired. I believe this was with a small patch. You can see the orogastric tube is returned back to its rightful place in the abdominal cavity, and there actually is some evidence of lung parenchyma within the left hemithorax. I think this X-ray on the right really highlights the degree of hypoplasia that these babies experience with most of that left hemithorax completely open space because of the hypoplasia that has occurred in utero. Occasionally, there is a role for ECMO or extracorporeal membrane oxygenation in the management of CDH. If this is can be life-saving technology for sure, but we found that with our ventilation strategies, as Dr. Desiraju has elucidated, we do not need ECMO in most patients. ECMO requires a neck incision in the right neck, where we actually put very large bore catheters in the right common carotid as well as right internal jugular vein. Veno-arterial ECMO is the usual mode of ECMO that we use because of the concomitant heart dysfunction that we see in these patients. We can do CDH repairs on ECMO, which is challenging, but most of the data suggests that it is optimal in terms of improving survival in this patient population. Most patients who do need to go on ECMO for CDH need to stay on typically for 1 to 2 weeks. And because these patients need to be on systemic anticoagulation, they are at increased risk for complications associated with anticoagulation, including bleeding, strokes, seizures, thromboses, and a higher risk for neurodevelopmental delay. So all things being equal, if you can keep a baby properly ventilated with a conventional ventilator or an oscillator as opposed to ECMO cannulation for 2 weeks, certainly the choice, the former choice would be sort of optimal in our hands. Feeding and nutrition is something that we do after repair. In the interest of time, I'll just comment that reflux and vomiting are quite common in CDH babies and actually explains a lot of their duration of hospitalization, including in addition to weaning oxygen from the ventilator. Care after diaphragmatic surgery is a very nuanced thing that's multidisciplinary. It requires pulmonary as well as cardiology specialists to help assist with the medical management of these babies, and is something that sometimes can be done after transitioning the baby out of the ICU to a regular hospital floor. Now, this slide really just highlights and summarizes some of our outcomes at Johns Hopkins, Baltimore. Our overall survival to discharge based on data over the last 3 years is 86% in comparison to national benchmarks, which is 70%. The percent requiring ECMO is about 20%, which compares to national benchmarks somewhere in the order of 35 to 40%. So much higher ECMO utilization in our hands. In our most severe patients, those that require fetal tracheal occlusion, our survival rates are 84%, and that's based over 20 or so patients that we've managed over the last decade. And even amongst those that require ECMO has been only 37%. And this is in a patient population that where the predicted ECMO utilization rate would be 80 to 90%. So I think that is one of the ways in which avoiding ECMO is one of the, I think, major benefits of doing fetal therapy for the most severe cases. An overall length of stay is about 6 weeks. I finally want to mention that because CDH is a multi-organ dysfunction disease with neurologic, cardiac, pulmonary, as well as GI issues. I think long-term follow-up is really essential to make sure that we get excellent long-term outcomes in these very sick patients. We have a multidisciplinary clinic in coordination with the Kennedy Krieger Institute, led by Dr. Joanna Burton, where we see all patients in a multidisciplinary fashion. We've had a lot of success in terms of improving the cardiopulmonary status of majority of these babies, and with excellent neurodevelopmental outcomes, particularly in the severe population, at routine testing at around 24 months of age. So in summary, at Johns Hopkins, I hope you have appreciated that we are able to achieve with a lot of multidisciplinary care and input, very high survival rates, often without ECMO. We have a wealth of experience here, and one of the benefits of our institution is the multidisciplinary and integrated team between prenatal and postnatal transitions. Thank you very much for your attention, and I think this concludes at least the presentation part of this webinar. Happy to open the chat for questions from the audience to our group. Thank you.
Thank you, Dr. Kunisaki. Thank you again to our experts for that informative presentation. We will now transition into our Q&A portion. As a reminder, you can submit your question using the Q&A function in your Zoom toggle window. So the first question we have is, we would love to hear about neurological outcomes after CDH repair and ways these infants can be prospectively followed.
Yeah, great question. I think I touched upon that a little bit in the tail end of my talk. There are multidisciplinary clinic at the Kennedy Krieger Institute. All the patients are routinely followed in a prospective manner for neurologic neurodevelopment. This includes very formalized testing at regular intervals, usually on an annual basis. And we actually just recently published our data on about 15 or so fetal patients in particular, and showed very exciting data, and that at the 24-month time point, based on both motor skills as well as in terms of language development, that over 80% or so of patients who have had fetal, for example, do not meet any criteria for developmental delay. So these results are quite promising. Certainly, there is the 20% that still have issues, but I think with intensive longitudinal care and follow-up, I think we can improve that population in the near future. I think some of the success that we've had is a product of avoiding ECMO, and particularly very long ECMO runs. I think that there undoubtedly is side effects that we're learning on brain development very early in life from requiring ECMO support for a very long time. We've learned that also from our cardiac surgical population. And so I think that's part of the secret, if you would, in terms of some of the exciting neurologic developments that we see.
Thank you.
I wanted to just add one little thing about the developmental impacts. So the scope of genetic testing for babies with diaphragmatic hernia has really changed quite a lot over the last 5 to 10 years, where it used to be standard of care to do karyotype. Now we have the opportunities for array testing, exome, or even genome studies. And that does pick up an additional 10% of babies that have actually underlying genetic abnormalities that do independently affect neurodevelopment and are not sort of due to the, oxygen impacts on the brain and all that. So, and I think that does make a difference in the counseling and the ability to give patients also good expectations prenatally.
Second question is, In circumstances where R is radial, PAL is unable to be successfully placed, can you talk through strategies to maintain the ventilatory management principles with knowledge that your blood gas data off with the UAC is not accurately representative of pre-ductal blood?
Oh, sure. Absolutely. We can talk about this. And so I think we're talking about preductal versus postductal blood gases here. Sometimes you can only get a postductal, and a postductal arterial blood gas is better than nothing. And we just have to be appropriately forgiving of the values that we get. The pH will be just a little better in a preductal blood gas, and the PCO2 will be just a little bit better in a preductal blood gas. And so we just need to be aware of that. As far as the PO2 goes, I would not make any decisions on a postductal PO2. And if you're in a conundrum trying to decide what to do for a baby, start nitric oxide, switch ventilators, and so on, it might be a good time to, even if you can't get a preductal art line, to just take a preductal sample, a one-time sample to check your oxygenation. But we use UACs also. We place UACs immediately after birth, and then once all the commotion dies down, once the baby's settled, then we place a right radial PAL. So we just need to interpret the values accordingly.
Thank you. Next question is, what do you see are the future directions in the neonatal care of patients with CDH? How do we continue to optimize these patients' care?
Sure. I mean, I think that this actually, what we really want to think about is the population that's undergoing fetal prenatally. And so I'll ask Dr. Bashat to comment on that, about the population that we offer feto to.
Well, I mean, I think gaining as much information that we can prenatally to strategize how you transition the baby postnatally is already an advantage. And it's very clear that centers where programs work together have better outcomes, because we learn from our neonatal colleagues and from our surgical colleagues and vice versa. So it becomes more of a care continuum from prenatal to postnatal. I think that is the real future. And I think the more we understand the physiology of transition from a prenatal perspective, and the more our pediatric colleagues understand the prenatal details as well, the better the care gets, right? And I think that's the future direction. And where you see the benefit most is, of course, the babies that are at greater risk, because they have very little margin for error because they're quite fragile, right? And I think so I don't think that the high survivals that we have with fetal is just for the balloon. I think it's actually from, working together through the care issues and learning from each other. That would be my way of answering it. There's one question about the flap versus the patch repair. I think that's probably an important one to bring up. What is the comparative strengths and weaknesses of patch versus muscle flap CDH repairs?
Yeah, I can answer that. So the patch repair usually requires an off-the-shelf patch. Usually the most common synthetic material is actually Gore-Tex, and it's customizable. It's you can make the patch as big as or small as you want for the size of the defect, and it's fairly straightforward. The surgical aspects of diaphragmatic closure, to be honest, are usually the most straightforward aspects of the care of these children. Increasing, though, what we've realized is that patch repairs are associated with a very high recurrence rate, particularly in the type D, the very largest defects that are managed. And because of that high recurrence rate, because that patch does not grow, it stays the same size while the child continues to grow and towards adult size. That's the etiology of the recurrences, is that essentially there's too much tension at that diaphragmatic repair, and then a hole develops again. And so in response to that, really something that is able to grow and remodel over time would be the ideal CDH repair. And so using your own muscle is really the direction that many centers, including ours, have increasingly embraced over the past couple of years. And the most common muscle flap repair is what's called a transversus abdominis flap. We've learned that from our plastic surgeons, and it essentially involves taking the innermost layer of the flank muscles on the left side and actually dissecting that and using that to obtain complete coverage of the hole itself. It is associated with a much lower recurrence rate. The downside of a muscle flap is it takes a little bit longer, and there were concerns historically that it was associated with more bleeding, for example, if a child is on ECMO. But I think most of the data really supports that a muscle flap technique certainly is a lasting repair, and we try to utilize that approach whenever possible.
Thanks. Our next question is, can you please describe how ventilation strategies or settings may change as bowel distension increases postnatally with air prior to operative repair?
Sure, this can be really challenging. And in order to reduce bowel distension, right in the delivery room, we place a replogal to suction, and we use cuffed endotracheal tubes. Usually we do inflate the cuff, but sometimes these replogals need troubleshooting. And our surgical colleagues have been very helpful with coming to the bedside and helping us troubleshoot these. However, there's only so much air we can get out. At some point, there's going to be air in the bowel, particularly if there was a difficult intubation that required PPV resuscitation prior to intubation in the delivery room. And in those scenarios, sometimes we may need to use higher settings in order to properly ventilate these babies. We may need to use higher PEEPs in particular as the bowel pushes back on the small lung parenchyma that we have. And I can jump right into the next question about high frequency oscillation. We start with conventional ventilation, and we've actually had great success with the jet. There's a lot of evidence with conventional and oscillatory ventilation, the oscillator, and less so with the jet. So we're facile with all three, but I will say that we've had really, really good success with the conventional and the jet. We always start first intention with conventional, and our settings are intended for conventional. There's a lot of information you can get from a conventional ventilator that really helps us assess the baby and see how compliance is changing over the first couple of days of life.
Okay, I think we have time for one more question. Can you speak to reherniation across these patients' lifespan? How prevalent is reherniation, and is there a special consideration to surgical repair?
Yeah, great question. The overall recurrence rate after diaphragmatic repair in the neonatal period is around 15 to 20%. But that largely is a function of how large the defect was to begin with. For the very large type D defects, the recurrence rate is probably on the order of 30%. And similarly, those that are where we don't need a patch at all of any kind and a primary repair is possible, recurrence rates are very low in general. I would say recurrent CDH repair can be challenging. These babies often are much bigger and stronger physiologically, so they can withstand reoperative repair without an issue. But as with any redo surgery, there's increased scarring, which makes the surgery sometimes more difficult. And so kids that certainly need multiple recurrent operations are classically amongst the most challenging patients that we do. So our philosophy really has been to repair correctly the first time. And if we do need to have a patch, to leave a large oversized patch, which we think reduces the likelihood of needing a recurrent repair.
Thank you, Dr. Kunisaki. We appreciate you joining our webinar today, and we hope this presentation has provided valuable insights into the prenatal diagnosis, treatment, and follow-up care for CDH. We also invite you to join us for our next webinar on fetal anemia, scheduled for Tuesday, April 8th. To register, you can simply scan the QR code on your screen, and a registration link will also be included in the follow-up email you'll receive later this week. Thank you again to our presenters and attendees, and have a great rest of your day.
Thank you.